Welcome back, focused learners. We made it. This is the 10th and absolute final masterclass explainer in our series. I am just incredibly thrilled to be here with you today as we celebrate your entire journey toward truly mastering these E&M coding guidelines. You've put in the hard work, you've memorized the complex definitions, and now we arrive at the grand finale. Today, we're putting all that theory to the ultimate test with some real-world, practical chart audits. We are going to lock in your mastery of COPA, the complexity of problem addressed, once and for all. Let's do this. Okay, let's dive into this. Our agenda today is packed with in-the-trenches audit walkthroughs. We've got Section 1, the finale hook. Section 2, Case 1 on diagnostic uncertainty. Section 3, Case 2 covering surgical chronic progression. Section 4, the 4-step master checklist. Section 5, the grand MDM summary. And finally, Section 6, our Decode Healthcare final wrap. Section 1, the finale hook. I really want to take a brief moment here to just acknowledge the phenomenal dedication you've shown over the past 9 parts. You have completely dedicated yourselves to the theory. But listen, as any experienced auditor knows, the real stakes involve applying those pristine rules to messy, unpredictable medical charts. So we are officially transitioning from theory learners to master auditors right now. We're jumping straight into the reality of chart auditing to see exactly how providers document out in the wild, and more importantly, how we absolutely must systematically code that documentation under the 2023 guidelines. So get ready, because we are conquering CPCOPA. Section 2, Case 1, Diagnostic Uncertainty. All right, let's put on our auditor hats. Now, what's really interesting about this case is how we filter a basic list of symptoms into a highly specific category under Table A. In this clinical scenario, we have a patient presenting with elevated homocysteine levels and diffuse worsening joint pain. The provider notes that the pain isn't hormonal and actually advises a primary care evaluation with a comprehensive workup to check for autoimmune conditions and inflammatory arthritis. Now, our audit breakdown correctly levels this as an undiagnosed new problem with uncertain prognosis, which automatically grants us moderate complexity. But why exactly is that? Well, here is your pro-auditor rule of thumb. It is not just about the localized symptom of joint pain. It's the fact that the provider's differential diagnosis actively includes conditions likely to result in a high risk of morbidity without treatment. The provider explicitly documented the need to rule out systemic, high-risk conditions like arthritis or autoimmune diseases. That is the key. Let's actually do a quick think-aloud audit together here. If a provider just noted, joint pain and said, take some ibuprofen, well, that's likely just a minor or self-limited problem, right? But here, the clinical data points align perfectly with moderate complexity because the workup was comprehensive and the conditions suspected actually carry a high risk of morbidity. The provider is actively managing the uncertainty of a potentially severe disease, and that firmly plants this in Table A's moderate complexity tier. Absolutely textbook. Section 3, Case 2, Surgical Chronic Progression. Excellent work on that first one. Now let's evaluate a completely different clinical beast. In this scenario, we have a patient with advanced right primary hip osteoarthritis. They're scheduled for a total hip arthroplasty, which means they require pre-op surgical clearance, specific orthopedic implant planning, and a 23-hour hospital observation hold. As an auditor, your alarm bell should be ringing. You should immediately recognize this as a chronic illness with exacerbation or progression, which, once again, lands us squarely at moderate complexity. And this brilliantly illustrates the vast difference between a run-of-the-mill stable issue and a progressive disease. Think about it. A stable chronic illness is controlled, it's routine, it's steady. But chronic progression, that is acutely worsening to the point of severely limiting function, demanding active, advanced surgical management. We're talking about replacing a joint entirely. The official definition clearly states that progression involves a chronic illness that requires additional supportive care to control that progression. The very fact that this patient requires a total hip arthroplasty and a hospital observation hold perfectly anchors this chart as a progressing chronic illness under Table A. The provider isn't just passively monitoring the arthritis, they are actively intervening surgically because the disease has significantly advanced. Section 4, the 4-step master checklist. To cut through the noise of any chart, you need a foolproof tool. But before you can even use our master checklist, you must verify the meet requirement. Never ever forget this. Simply listing a problem or a diagnosis in the chart does not increase the level of service. The condition must be actively addressed. You literally must find documentation of monitoring, evaluating, assessing, or treating. If a problem doesn't have meat, it's just passive background history. It is not a managed condition. So, the crucial point is applying these 4 definitive steps to turn any complex medical chart into a clear, undeniable code. Step 1. Filter and isolate. Use meat to find what was actually managed today. Step 2. Classify the type of those managed problems. Are they acute, chronic, or minor? Step 3. If it's chronic, evaluate the severity. Is it stable, uncontrolled, exacerbated, or severe? And step 4, if it's acute, evaluate its severity. Is it uncomplicated, or are there systemic symptoms? Follow this flow, and I promise you will never get lost in a provider's notes again. Section 5. The Grand MDM Sorry. Now, we focused really heavily on COPA today, but remember, that is only one piece of the puzzle. To formulate the final E/M level, you must combine your Table A results with the amount and complexity of data to be reviewed, which is Table B, and the risk of complications and morbidity, which is Table C. It's the combination that gives you the whole picture. And it all comes down to the golden rule of MDM. The final level is always based on 2 of the 3 levels arrived from each table. Let's do a quick high-energy example. Say your chart audit reveals Table A is moderate, Table B is limited, and Table C is moderate. Will you take the best 2? Since 2 of them are moderate, your final level is moderate, securing you a 99204 or 99214. It is literally that beautifully logical. Section 6. The Decode Healthcare Final Wrap. If you have followed along with us from Part 1 all the way to Part 10, you have officially graduated. You have elevated your skills from basic theory to real-world application with incredible precision. I want to leave you with this direct quote from our source material. Happy learning, happy coding. Let this serve as an inspiring reminder that the journey of a master auditor is one of continuous, lifelong learning. The guidelines will evolve, the charts will get way more complicated, but with the rock-solid foundation you've built here, you are ready for absolutely anything. Thank you so much for joining me on this incredible deep dive. As you step out of the theory and into the real world, I want you to ask yourself, when you open your very next chart, will you just be reading history, or will you be finding the meat? Please take a second to hit that like button, share this masterclass explainer with your fellow coders, auditors, and clinical teams so we can elevate this whole industry together. And definitely leave any of your questions down in the comments below. Until next time, this is Decode Healthcare with Harshal, signing off.